everyone. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Welcome to Spine Talks, where we bring unparalleled access to world-class experts like the doctors who are joining me today. I'm delighted to be joined by members of our Medical and Scientific Board who comprise our Spine and Bone Health Task Force. The Spine and Bone Health Task Force is led by Dr. John Dymar, who's on our panel today, along with his colleague, Dr. Paul Anderson. The Spine and Bone Health Task Force is focused on looking at challenges with bone health and how we can best educate the public about this very, very important topic. So I'm going to turn the program over to our moderator, Dr. Tom Schuler. Tom?
Thank you, Rita. It's so exciting to be here at a major meeting to talk about something which is so critical to all of our health. I mean, without our spine, without our bones, we're a blob, we're an amoeba. And so the question is, how do we optimize our health? How do we prevent problems? And we're going to use all of our experts today to try to get you some information so that you know how to best protect your body and to have the best quality of life you can because of that. So we have Dr. Sardar, we have Dr. Dymar, we have Dr. Elders, and we have Dr. Namani. So gentlemen, if you could introduce yourself, say where you're from and your background and what you're doing.
Sure. So I'm Zishan Sardar, as you said. I am a spine surgeon in New York at the Columbia University and New York Presbyterian Hospital. And currently I treat patients, adults as well as adolescent patients with spinal deformities and other spinal problems.
My name is Dr. John Dymar. I'm one of the co-chairs. I'm from Louisville, Kentucky, from the University of Louisville. I'm a professor there, and I treat adult and pediatric spine surgery and have a particular interest, as all these gentlemen do, in osteoporosis.
I'm Dr. Benjamin Elder. I'm a neurosurgeon at Mayo Clinic. My specialty is in treating patients with adult spinal deformities. And then I also have a basic science lab for bone and cartilage tissue engineering.
My name is Dr. Vani Namani. I'm an orthopedic spine surgeon at Virginia Mason Franciscan Health in Seattle, Washington. My practice is about 50% taking care of patients with adult spinal deformity, and the other half is taking care of other problems with regards to both the cervical, thoracic, and lumbar spine.
Let's start this. Let's talk about some definitions so we can help the public understand. So can you help us in a little conversation about what matters in bone health?
Well, I think it's important to realize that each and every one of us, as we get older, will have loss of bone. And it's a natural aging process. It's both pathological, and in some people it occurs earlier and more aggressively. But most people, by the time they're in their 60s or 70s, will have some degree of what we call osteopenia. And that's really just a term that means that you're starting to get weakening of your bone. That's probably not significant as far as having a problem with it, but should be looked at. So that's osteopenia. And of course, once we get older, and particularly over the age of 70, it progresses to a point in certain people, but many people, that it develops in what we call frank osteoporosis, which medically simply means that the bone has reached a level of loss of strength due to loss of calcium and the structure of the bone, that you may actually just suffer a fracture with a minor injury or with a fall. And that's where we often see people come in with broken hips, or particularly in our case, fractures of the vertebral bodies. And these are considered a real problem because one leads to another. And that's why one of our goals is to know and educate the people out there. When you hear osteopenia versus osteoporosis, it's just a degree of worsening of the strength of your bone, think of it that way. And that we want to identify that early. And we want you to understand those terms so that you can go and speak to your healthcare providers, whoever that may be, and say that this runs in my family, for example, or they suffered a minor fracture and were seen and it wasn't treated. Those are signs that you may need additional treatment.
I'd like to ask the panel to comment on the definition of osteoporosis, because I think there's some confusion. If you've had a fall and you get a fracture, does that mean you have osteoporosis?
I would say the short answer is yes. If you have essentially...
At what age?
So if you have a fall from a standing height, that means if you're walking around and you slip and fall and you break your hip, you break your wrist or distal radius, you break your shoulder, or you break your spine, that is the definition of what we call a fragility fracture. It basically means that the bone broke from a force that should not have caused it to break. And so by definition, that means that you have osteoporosis. Now, there are other ways to diagnose osteoporosis outside of having had what we call a fragility fracture. And those are things like the DEXA scan that we talked about before. If you have a T-score of less than minus 2.5, and essentially that's comparing your bone density to that of a young, healthy person.
Yeah.
Another way is looking at a FRAX score, which kind of combines several of these factors to looking at your 10-year fracture risk. And then there are some more advanced tools that can be utilized, such as what Dr. Elder mentioned, trabecular bone score, using specialized types of CT scans. And so there are various ways to do it.
A lot of patients show up to us and they have these fractures and they never knew that they had osteoporosis or osteopenia. They weren't treated for that. They weren't even identified to have that problem. So I think, just like you said, I think one of the key issues that we're facing is really that early prevention as well as identification of these problems. And then later on is the treatment for those who get these issues. So I think, as we're talking about today, we're hoping that we kind of spread that message as well to younger people as well as the older people. That all of us have bones, all of us have spines, as you said, and we need to take care of it from an early age so that we can have a better quality of that bone later on as we age. And then, obviously, in the older population, then it becomes a role for screening as well as in medical treatment. But the hope really is that we get to things before that even happens.
So Venu, to me, the best treatment is prevention. So let's talk a little bit about, for our adolescents, for our young people, let's talk about how we build that bone bank, that concentration of bone that we live off for our life.
Yeah, so Dr. Dymar mentioned that, we kind of lose bone as we age, and actually everyone reaches their peak bone mass at around age 30. That means up until age 30, you can build your bone, but after that, it is a long slide downhill. And so whatever you can do to increase whatever that peak bone mass is by age 30 is really critical, because after that, you're just trying to, prevent your bones from degrading to the point where you do get either osteopenia or osteoporosis and are at risk for fractures when you're older. And so I always tell patients, especially when patients come in, they often have their younger family members with them, right? And so whereas a patient who might be seeing us for a fracture or some other spinal problem, it may be too late for them to build their peak bone mass, but for their family members, what they can do when they're young is to get plenty of regular exercise, which I think is probably the most important thing, a healthy diet, full of all the usual things that are just healthy for your heart anyway, and also avoiding other harmful habits like nicotine exposure through smoking or other tobacco products, which is a very, very strong risk factor for poor bone health.
And I would add to that, soda drinks, caffeinated drinks, all those things leach bone, and you got to have adequate calcium and vitamin D in your diet. So,
for sure.
Well, I have a question about that with nicotine and smoking. I think that a lot of people think that vaping or e-cigarettes are safer and not as damaging. Is that true, or what do you tell patients about that?
So it definitely is damaging, especially anything that contains nicotine. I think there's still lots of data that's going to be coming out on those sorts of products, but certainly while it may not have all of the chemicals that cigarette smoke have in them, the presence of nicotine itself is really toxic to bones and toxic to spinal discs. A lot of the problems that we see in patients that end up needing spine surgery actually are caused by nicotine exposure. And in fact, the patients that we end up doing surgery on, nicotine exposure or nicotine in their body leads to a dramatically increased risk of complications.
So, Ben, you're always healthy till you get sick.
Right.
Okay? And when we're talking about the folks out there looking at this stuff and thinking about, when I go to my doctor, what should I ask him about osteoporosis? And just like the doctor checks you for high blood pressure and diabetes and a lot of other things, should I ask my doctor, and what should I ask my doctor to look at? Because bone health is so important, and remind him.
Right. Yeah, I think absolutely talking with your doctor is critical. And I think that's true for people throughout all stages of life. For pediatric patients, it's making sure they're getting adequate calcium, whether through dairy products or depending on their diet if they need other supplements. And then getting adequate vitamin D intake as well. That's probably especially true for patients in colder climates like we have in Minnesota, as a lot of your vitamin D comes from exposure to the sun.
And there's no sun in Minnesota.
For a few months of the year.
For the audience out there.
And so for patients that don't get adequate exposure to the sun, it's important to take supplements, or that you may need to take supplements, but it's good to check with your doctor to see if that's necessary and what dosing you should be taking and how to check that. Additionally, patients who go through early menopause may be at much higher risk of developing osteoporosis. And so you should have discussion with your doctor for hormone replacement therapy if
And
needed.
that's 50% of the population.
Can I add something? I mean,
Absolutely.
I'm so glad you guys are talking about kids right now because, I mean, again, we focus a lot on adult population. But in my clinic, and I think it's well published as well, a lot of kids that are coming in with scoliosis have vitamin D deficiency. And one of the kind of non-operative protocols in terms of treatment for this is to make sure that they're getting enough vitamin D. So I think it's key that we're talking about this stuff today, not just about the older people, but also kids that the prevalence of vitamin D deficiency is pretty high in the United States. Especially, it's especially higher in those areas with some of the lower socioeconomic status. So even within cities, you'll see variation. We see a lot of that. We do treat a lot of underserved communities in New York. And we do see a lot more vitamin D deficiency even in those populations in kids. So I think it's just key that vitamin D is looked at almost for everyone. I think pediatricians do need to start looking at that more. I know in my house everyone gets vitamin D, including myself and my kids. So I think it's just very important that we're talking about this starting from the kids going up to the older population.
Do you think that vitamin D deficiency is from diet? Do you think it's genetics? Why do you think that's happening?
I think it's a combination. I mean, I think we know that again. Exposure to the sun is a key factor, depending on the region you live in. But I think also our lives have just changed, right? We spend a lot of time indoors.
Yeah.
On computers.
On computers, on video games, on iPhones now, more than anything else. So I think that, especially for the kids, they're just not getting as much exposure as let's say people were getting 30 years ago. So I think that's a fundamental change that's happened over the past few decades. Has changed. I think nutrition is a big thing as well, and again, like depending on which milk products or other calcium products you get, they do add vitamin D supplements to it. But still, I think again, even my kids were struggling with making sure that they get enough milk, so that may not be enough. And so I think with that, you have to just make sure that they're getting enough vitamin D there.
Absolutely.
And when we talk about the socioeconomic status, it's also the cost of the supplements, right? So we have had patients from some of the underserved communities who have gone, who we say, hey, take vitamin D, but those supplements are not that cheap. So hopefully, as the awareness grows and more, I guess, like generic and cheaper products come out, that'll be easier. But I think everything kind of adds into it. If you look at some of the, I get a lot of international patients. So when we look at those, and even though they have a lot of sun actually in those regions, they're coming from the Middle East and also some from North Africa. So there's enough sun there, but those patients are actually more vitamin D deficient than some of the patients that we see. So I think there is definitely a component of nutrition that's built in there and just in other activities and going out there.
And the consequence for the audience is, if you remember the disease called rickets, where you get bowed legs and deformities, and it's a lifelong damage to these children. And so we just had a child that came in with vitamin C deficiency. We have them all the time with vitamin D deficiencies. And so it doesn't just apply to older people, since we've touched on it. It really, you need to make sure your children have adequate vitamin D. Now, we put that in the milk that they should drink, but a lot of kids don't drink milk nowadays. And it's pretty tough to shove a teaspoonful of cod liver oil down a child's throat. So you have to pay attention to that, and all of us have seen these patients come in because they do not go outside and get sunlight exposure or play outside nearly as much as they did a decade or two ago. So pay attention to your children. We've even checked children's bones, and we find that between 9 and 14, they will actually dip down as far as their bone strength. And remember what Venu said about how you can add to your bone till you're 30. The formative years to do that is the teenage and growth years. That's when you make your skeleton stronger. So it's very important, since we've touched on it, that you check your children also.
And going back to your original comment that bone loss is healthy or is normal throughout life, and we expect that to happen as you get older, you can think of it kind of like a gas tank, where when you're young and developing up to the age of 30, you can fill up that gas tank. So if you're starting off with a full tank and then you start using that up throughout your life, it still may be half full, which is healthy enough and prevents any sort of fractures down the road. But if you're starting off with a empty tank already, you're going to end up with problems down the road.
Ben, Ben and Venu, what would you do in those formative years to build that tank up?
So this has been touched on, but I think that, making sure that you get plenty of calcium, vitamin D, lots of exercise. Some bad habits also start pretty early, and so, we know, unfortunately, as kids get out of the house and they go off to college and they start to, smoke and do other things that are not necessarily
And be nocturnal.
and be nocturnal, right? These are all the things that are not very good for your health overall, and certainly not good for your bone. And so, trying as best as you can. It's easy to set good habits early, and then maintain them, than it is to change bad habits. And so trying to, at an early age, establish a foundation for good bone health and good health overall, and then maintaining that as you enter early adulthood.
Excellent.
Dr. Dimer, I have a question for you. We've been talking about calcium supplementation for kids, for young adults, and even for older people. And I think a lot of people are confused about calcium supplements. Like, what's the right one to take? Am I going to get a kidney stone? Am I going to overdo it? Can you help us understand a little bit about, and maybe everybody could talk about that a little bit?
Well, I think one thing with real quick on the children is get them out from in front of that video game and get them out in the sunlight, and about every half hour flip them over and basically get the sunlight.
Up with sunscreen.
Yeah,
Is that
you only
effective?
need a few square inches and for about half hour to make enough vitamin D for the day, and that's one of the big causes. As far as calcium, I think most good diets, which are frequently not the case of children, a lot of our child I mentioned earlier, all they ate were Doritos all day long, and so which causes vitamin B2 deficiency also. But the whole point is that most good diets with vegetables and fruits will get enough calcium. And that's true for adults and children. So calcium supplements are generally used in situations like for a pregnant woman where they have a lot of calcium loss or certain diseases or things. If you have kidney stones, you may not be able to take calcium, it may just be dietary. And so calcium is probably less important than vitamin D3, but vitamin D3 in people with normal metabolisms or normal health, the VITAL study that came out said it's probably not beneficial. But that assumes that you're doing all the things that we've been discussing to keep those levels at normal. We checked every surgeon after Joe Lane came in and talked to us about bone health. Every surgeon in my office was checked for vitamin D levels, and we all were low. So we all take vitamin D3 now. And so that's how pervasive this is.
Yeah.
And so I always think that vitamin D, and I hope everybody would agree with that, is probably the most important key because it allows you to absorb calcium and it regulates things in your kidneys and all sorts of things. It's almost like a hormone in a way. I think that's a little bit more important than calcium. Calcium is mainly for if you're in situations where you might have some sort of calcium loss issue.
And I think an important follow-up to that is that people always come in and say, well, I don't have a calcium deficiency because my blood level calcium is at a normal level. And the answer is if your blood calcium level isn't at a normal level, your body's electrical system for the heart, for everything else doesn't work. And so it's going to get a calcium from somewhere. And the source, if it isn't in the diet, is the bone. So a blood level of calcium tells you nothing about your bone strength, tells you nothing about whether you have enough calcium in your system, because if that gets out of kilter, you got bigger problems. So,
you will become profoundly osteoporotic, the worst situation of your bone, to maintain that calcium level, because as Tom said, if it goes out of whack, you're going to have some very major seizures and plasticity. You'll basically get paralyzed and your heart will stop beating. And so it'll keep sucking and sucking bone out of it, which would bring us to other things, of course, eventually we'll talk about that can cause osteoporosis. But it's very important. But most people will maintain a pretty decent calcium level unless they have something else that's out of whack.
One other thing I would add is I'm always surprised by how many adults don't go see their primary care provider or doctor regularly, and I think that preventative health in general, we're talking about osteoporosis today, but just general preventative health of, getting your cholesterol checked, getting your blood pressure taken, and having your primary care doctor check these things. Oftentimes, osteoporosis can be caused by other things, like having an elevated thyroid level, and having that being a reason why calcium is leached out of your bones, or an elevated parathyroid level. And so I think just general preventative health and seeing a primary care doctor on a regular basis to prevent a lot of these things is very, very important.
Yeah, that's a fantastic point, Benny. Thank you for that. I think it sort of makes me remember that I'm on a panel. I'm on a panel with surgeons today, and the surgeons that we're talking with today are concerned about bone health, which a lot of people think is a primary care problem. But really, bone health is everybody's problem at every age and every stage. And certainly, surgeons cannot do the work of their surgery if the bones aren't there to support that. So, it's fascinating to me that these surgeons are so concerned about getting this message out to the public that yes, general health and wellness is important, but your bones take you through life. And if you don't have your bone health, you don't have your life. And that's kind of what we're talking about today. And so I think, speaking, to you, Dr. Dunmore, you've been at this as a spine surgeon for 25 years, 30 years, and we're talking about seeing epidemic levels just continuing to rise. How do we turn the tide?
Well, Zisan, what do you think? You're an expert in this.
Yeah, I mean, I think great question, and that's why we're all here. And that's the message we're trying to get out to the people is how do we turn the tide? Because it's not going to be me telling someone or it's not going to be a couple of us. It's going to be increasing this awareness from the ground up, right? And so as we were talking about, even though the problem is really more so seen in adults, so we're talking about kids, right? Because I think that's where we can make the best or the most impact is make sure we get that bone stock in
Yeah.
so that everyone's going to lose bone as we talked about eventually as we get older. But we educate people on how to build that bone stock early on so that you kind of start off at a higher level and then also maintain it somewhat at a better level. And I think we'll get to it soon as well. But I think to me that's the key. The key is getting the message out there about the importance of bone health, about starting early for kids and young adults. And then talking about as you get into your middle age and into the 50s and maybe higher is then the screening of it. Now you're looking at the other side of the coin. Now you're looking at okay, well now you've gone through your peak bone and you are on the slide down. How can you slow that slide? And have you reached a point now where you really need to now start more like stronger medications or treatment and things like that? But
Absolutely.
I think that's really the key. Start early. And just two things. I mean, I think that I wanted to emphasize a little bit more were in exercise, and I think we didn't talk about weight, and especially for our teenagers, for our young adults, weight becomes a sensitive topic. But I do want to talk about it a little bit because,
When you say weight, what do you mean?
well, your body weight,
Whether you're overweight or not, whether you're overweight or not.
or underweight.
Okay.
Or particularly morbidly. So.
Yeah.
So all of them, because I think there's a bit of, there's a lot, especially social media. People talk about body image, being overweight, or honestly, I think what we don't talk about a lot is being underweight. And what we see on the adult side of things is, and also in the kids, if we check their levels, is in patients who are underweight end up being more nutritionally deficient, and it's often these really underweight people who try to really keep a very low diet and probably weren't getting enough nutrition. They end up with really poor bone quality as they're older in life. But at the same time, people who are morbidly obese have the same problem, right? And there is a good middle ground in between where you kind of maintain a healthy weight and you're active because it's a combination of weight and movement that builds your bones. The body is meant to respond to the needs of the body, right? So if you're really low weight, the bones don't need to carry a strong weight, a heavy weight, so they're not going to be as strong. But if you're really heavy and you're just not walking as much, it kind of gives the same result. You're just not putting as much force or stress on the bones to build it up. So both ends are not good. And I think we just need to again emphasize if someone of a middle, a more healthier weight, nutrition, weight, as well as exercising, which is more so weight-based exercise. I see a lot of people who are bicyclists, and I do think there's a little bit more prevalence of weaker bones in that because again they're working their heart, they're working muscles, but they're not. It's not a weight-based exercise.
Better not fall.
Exactly, you better not fall. So I think that weight, the weight-based exercise, even if light weights, that helps build the bone early on as well.
Well, that's the importance of strength training and stuff. So Ben, let's start shifting a little bit. When people come to see a physician, especially let's say spine surgeon, since we're all spine surgeons, what should we be thinking about understanding their bone strength and at what point in their care?
So I think it depends what they're seeing you for. So a lot of my patients come because they already have an existing spinal deformity and often need a pretty major surgery with a multi-level fusion, which means putting in lots of screws and rods to straighten out the spine and restore the normal alignment. And so the best, going back to another analogy, the best one I use with my patients is that if you think about putting a screw into drywall or into a stud, there's a big difference. And with some of the patients we get with severe osteoporosis, it's pretty similar to the paper on the drywall, whereas anything you put in is just going to rip out of that bone immediately. And that often leaves a much bigger hole than the screw tract and can often be unrepairable at that point. And so it's critical to get these patients their bone health, or it's critical to improve the bone health in these patients prior to surgery to prevent catastrophic complications afterwards.
So Ben, the patient walks into you, you do something special. You do testing and you have a good thought process. Can you tell the audience how you would really identify and work them up and just kind of the basics of your treatment to get them ready for the surgery you're talking about, some of the things?
Sure. So when we see the patients, one of the standard tests that's accepted worldwide is a DEXA scan, which is really just taking a radiographic view or kind of a low radiation X-ray of the spine and averaging it together. In patients with spinal problems, this is actually a pretty poor measurement of their bone density because it just averages everything. And a lot of patients have things like bone spurs that really will falsely elevate it and make it look like a normal value. And so looking at other sites like the hip or the radius are usually a little more helpful in these patients, but even that doesn't identify a substantial number of patients that do have problems with their bone health. There's other tests that we can use, something called the trabecular bone score, which looks at the organization of the bone. You can think of it like an Eiffel Tower, where it's well organized and it creates a very strong structure, but if you just take that same pile of metal and randomly put it together, it has no strength. Another issue we can look at is something called the FRAC score, which helps predict their fracture risk, both for a major osteoporotic fracture as well as a fracture at the hip, and either of those can also identify problems. And then lastly, we've been looking at something called Hounsfield units, which is just a measurement we can take in a few seconds off of a CAT scan that all of our patients get for surgical planning. And we've identified a lot of different thresholds where patients will have much higher risks after surgery based on these numbers.
So you're going to do very specific laboratory work, and there are very specific x-rays that you have to do to identify osteoporosis. And those have to be done at certain stages or certain points in your life. Or if you have any of the problems you talked about, the FRAC score is just a sheet of paper that, for example, if you have a fracture that happened that you just had a minor fall or you rolled over in bed, by filling that form out, and your physician will ask you that, it automatically tells us that you almost certainly have osteoporosis. So there's 3 ways to do that he mentioned with a CAT scan that you're all familiar with a DEXA scan, which you should be familiar with. It should be done by your family doctor. And of course, the FRAC sheet or questionnaire that we give you and ask you questions about your lifestyle. So,
and one thing I would just add to the FRAC score is that anyone at home can do this. So you can just go and type in FRAX, score, and it'll take you to the website, and you can punch in your numbers, which includes your age, your height, your weight, some other risk factors. You can even put in your T-score from your DEXA scan if you want yourself, and it'll actually give you a fracture risk. And at the bottom, it'll tell you your risk of a major osteoporotic fracture and your risk of a hip fracture. And you can actually print that out and take it to your primary care provider.
When would you suggest that our audience gets their DEXA scan done? It's a very important, somewhat controversial.
Yeah.
Should be just like getting a blood count at your doctor.
Yeah, I think, again, this kind of goes to the preventative testing, that should be done. And several of the different societies have come up with different guidelines, I think,
Yes.
for when this testing should be done. But I think in general, if you are a postmenopausal woman, and it's already been mentioned before that as hormonal changes happen, those are the times where especially women are at higher risk for developing osteoporosis. One other thing I would add in terms of the diagnosis of osteoporosis to all the things that Dr. Elder said is that sometimes you go in to see, like what we see are patients that come in for evaluation for spine surgery, and you look at their x-rays and there's already a fracture there that they don't even know about. And so at that point, despite what a DEXA scan would say or what any of these tests would say, that person has clinical osteoporosis if that happened either through no mechanism that they remember, or from a minor fall or minor injury, you know? And that itself means that the bone is not strong, it's not withstanding the loads that it should withstand, and it should be treated.
So you think that a woman ought to certainly have a DEXA scan by the time she's 60?
I know that I recommend that for my family.
And if she has premature menopause or early hysterectomy with her ovaries taken out, or a strong family history, or has renal disease or has liver disease, that those might be some other people you might want to consider doing a DEXA scan when they're 50.
100%. Just like we, modify our screening guidelines for people with risk factors. Let's say someone has a strong family history of colon cancer, they may start getting their colonoscopies much earlier than the typical age of 45.
Unfortunately.
So
But
yes.
I must say, but
Yes.
don't forget the men out there that you catch up to the women by the time you're 70. And so you need to pay attention to that too, particularly if you're a smoker or have some of the other things, diabetes or kidney disease, that you want to make sure that you're included, the other half of the population, because men get osteoporosis, and particularly low T. If you have low testosterone, it's easy now, everybody knows what low T is. You watch the commercials on TV where you take supplements now and you become an instant great baseball player and everything. But the point is that men get this too, and so you also may need this DEXA scan we're talking about.
I think that's a critical point to highlight, is that traditionally, I think there's still a lot of belief out there that osteoporosis is really a disease of women. And we see a substantial number of men that have issues with this. So it is critical that men think about it too.
So we end up testing our bone density in any patient who's going to have a spinal implant,
Right.
especially since we're doing so much disc replacement, where we're relying on the ends of the bone to support the construct, the implant. And we're shocked to see how many men and women under the age of 50 have osteopenia or osteoporosis, so soft bone. And that may impact what we choose to do. So I think it's something that before anybody gets a spinal implant, that should be part of our routine workup, and it isn't just the elderly. I think it's across the entire gamut, and you mentioned that.
Yeah, I completely agree. And we published guidelines on that a couple of years ago. Spine surgery patients, a little bit different from the general public, right? Because now we're putting more stress, mechanical stress on those bones. So just like you said, for us as well, it includes men as well as females. Automatically, if you're above 65, you'll get it, but over 50, pretty much anyone in my practice, we screen them for all the things that Dr. Daimar mentioned. And if you have, including in addition to that, smoking and alcohol use, and if you have any one of those and you're over the age of 50 and you're getting any implant placed, we'll get your bone tested to make sure you don't have high osteopenia or osteoporosis before you're going to have spine surgery, so that hopefully we can treat that for a better outcome for surgery, because we are going to be then putting an extra load on your spine. The demands change compared to someone who hasn't had surgery.
One other point I would mention also is that osteoporosis is really a silent disease until all of a sudden you develop a fracture. And so many times we see patients in our clinics who come with a spinal problem and they're in pain and they want their treatment soon for their spine problem, but then in the workup we identify osteoporosis, and at that point we say, well, look, we got to hit the brakes here and we got to treat this other thing, which is going to take several months before we can treat you and do a good job on your operation so you have low risk of outcomes. And so again, I think prevention is really important, because you don't want to have some other problem that comes up, and because your bone quality is not good, have that prevent you from getting the other care that you need.
Well, you're saying prevent, but why? Well, explain to the public why that would prevent you from doing that other care.
Well, so as Dr. Elder was saying, I think all of us treat a lot of complicated spine problems, especially where we rely on screws and rods and these other implants that go between the bones to realign the spine and to stabilize the spine. But if the bones are not strong, the implants themselves won't hold very well. Or even if the implants hold, the bones won't actually grow together and fuse, which is a goal of many of our spinal realignment operations. And so we really want to make sure that the bone is optimized going into the operation so that there is the highest chance of a good outcome and the lowest risk of a complication.
And I think the population you addressed previously, where they come in and you identify a silent fracture that they didn't know about, the biggest risk of a second fracture is having a history of a first fracture. And so, number one, that shows that they have poor bone quality to begin with, or poor bone density.
The fracks.
Correct. And then, but number two, it's also once you have a fracture, it can change the alignment of your spine and start putting more stress at the adjacent levels. And we have some patients that quickly go from a pretty normal alignment to a severe deformity over even, I've seen it in 6 to 12 months from having multiple fractures right next to each other.
So for the audience, we keep talking about prevention, and identification. If you have one spinal fracture, there's a chance if it's not treated, you're going to have another osteoporotic fracture within a year, 50% of the time. If you have two, it's going to be 100% of the time. Almost a domino effect. And so prevention is so important, identifying all these things. And when we keep talking about lifestyle for you folks out there, it's very important. You know, if you drink too much, it affects your liver. And your liver basically makes vitamin D. So you become vitamin D deficient. So you develop osteoporosis. Okay, and all these lifestyle things are really critically important. And that's why we want to identify and counsel you to think about these things, because it will make a difference in your bone health as you get older and everything. And so prevention is so critically important. And if you know these things, Rita likes us to talk about scientific evidence. But with me, scientific evidence is common sense, okay, of what you expect something to happen. And we have study after study after study that shows if you have osteoporosis, that you're not going to do as well in any surgery we do on you. And that's common sense. And it makes sense that if we can't put a screw in your bone to stabilize your spine because it's too soft, that we may not be able to help you with a very serious problem. And so that's why circling back around to the idea of prevention and identification is very critical for all of you.
Well, let's shift right now. We've talked about getting strong bones as a kid. We've talked about identifying it in treatment. Let's talk about the miracles that exist now in our therapeutics. So I'll throw it out to the panel. Let's talk about what are the different treatment options available now once we've identified somebody who has a problem with their bone that didn't used to exist. And part of this is the benefit of genomics and genetic engineering that's come up with some products. But let's discuss the amazing technologies that are out there today.
So let's do it stepwise. Why don't you talk about the basics of calcium and vitamin D and what we do, and I'll talk about perhaps some of the first tier drugs we call bisphosphonates. You can talk about the anabolic drugs, each one of you, about rosumab and denosumab. So
Yeah, so I mean, just like we were talking about, I think the most basic thing in terms of treatment is nutrition, as well as making sure that we have enough of the baseline substrate to build the bone. Because and we'll talk about other medications, all the medications that we use eventually need a certain amount of raw material to be able to make that bone, and that's vitamin D and calcium. So for patients that come to see me in my practice undergoing any surgery, doesn't matter if they're old or young, we make sure that we check their vitamin D levels. And then calcium, like you said, most of the time it's normal, so we will counsel them on making sure that they're getting enough calcium and they have enough of that in their diet. But vitamin D is something we can check to make sure they're not deficient in that, and if they are, we get them to get supplementation. Why is vitamin D important? As we were talking about, vitamin D is important in telling the bone and the rest of the body how to build up that bone stock and how to add that calcium where it belongs, or sometimes if there's not enough, where to take that out from. So I think the basic foundation for everyone when we talk about general thing, and again, it goes into just, I guess, natural treatment of everything as well, is making sure you have enough of the basic substance, which is vitamin D and calcium, to then build up your bone with the use of other medications. And then you guys will talk about the other stuff.
well, my job, over the last 3 decades, we have had some very significant, marvelous improvements in the ability to treat osteoporosis that did not exist. And that's been really just some fabulous science that has been done to identify the pathways that bone forms and how we can modify that with medications and drugs and injections and a lot of other things. The first of those, of course, was just basic metabolism, vitamin D. The second was the development of what we call bisphosphonates, most notably, its trade name Fosmax, but it's a bisphosphonate. Bisphosphonates were the first drugs that came out in the 90s, and then our other panelists will talk about the ones that have come out a decade later, one called denosumab or Prolia. And then, of course, more recently, we've had the teriparatides, which actually build bone, and more recently, another new drug called romosozumab, which actually will work in a different way to build bone. So the first drug were the bisphosphonates, and they've been out for about 20 years. And they're taken orally, but more commonly now, we just do an IV on you about twice a year. And what they do is they slow down the loss of bone, essentially. And they do have time limits, they do have specific dosages, and with all medications, they do have some side effects, of which are quite minimal, the most notable being that you can get some jaw tooth loosening, particularly implants, and that really scares people a lot. But the incidence with an oral is higher than with the IV, which is what most people use twice a month now, and it's a 1 in 100,000 you get that. So the first line drugs are called bisphosphonates. That's most likely what you're going to be treated with first, particularly if your osteoporosis is more on the mild side, and it's very effective, and there's a time limit of 2 to 5 years depending on the situation that you're in, and it's been very, very effective in slowing down the amount of bone loss. Now, it's important, remember how we lose bone from age 30 all the way until the day in your 70s and 80s, gradually losing it. What slows that loss down, and that along with vitamin D, which slows the loss down, and good calcium intake is one of the ways we treat it, so that you end up with not developing bad bone or soft bone as quickly. And that's our first line drug. Okay, that's the first tier drug. So the second tier drug.
Well, so I think so when we go back to bone health, I think a lot of these drugs are based on their effects on the cells that help maintain your bone. And so it's really a mix of there's different types of cells. So one is osteoblasts that really help to deposit new bone, and then osteoclasts that help to break down the bone. And constantly throughout your life, both these cells are working back and forth to constantly remodel the bone. Since I love analogies, it's like you're constantly changing out the roof on your house. So you are constantly having a fresh roof. If the osteoclasts, which break it down, start removing extra shingles from your roof, you're just going to start having problems. And so one of the other drugs is called denosumab, or the trade name is Prolia. And so this one blocks the cells that develop into the osteoclasts that break down the bone. And so they just kind of build up where this blockade is of what we call the pre-osteoclasts. And so it prevents them from breaking down the bone, so you get extra deposition of bone. The challenge with this one is once you stop it, all of a sudden it releases this huge number of osteoclasts that will then break it down. It's kind of like holding back a bunch of kindergartners, so now you have 200 kindergartners and you release them into first grade, and you're going to have problems. And so the order you start some of these medications can also be important. And so romosozumab is one of the newer drugs, which is a sclerostin inhibitor, which is another protein that's involved in your bone metabolism. And so if you start drugs like denosumab before that, you may not get as much of an improvement. And so that romosozumab is given once a month as an infusion. And this one really seems to stimulate the osteoblasts more to deposit new bone, both on the cortical rim, which is the harder part of the outside of the bone, as well as the inside of the bone. And then
Needless to say, it's extremely complicated for the audience out there.
Ben, I wanted to ask a question about denosumab, and I think it's important, just to kind of split that as well. And just like you said, I think you mentioned it. It's the bad effects of stopping it. Can you elaborate a little bit more on that? And the reason I asked that is that I have had a couple of patients who, for different reasons, stopped that or missed the dose, and now for a year or so haven't had it, and then they've had multiple compression fractures, spontaneous, and bigger issues than where they started from. So how do we, is it safe to stop? If you want to stop it, do you transition to something else? What are your thoughts on that?
Correct. Yeah, that can always be a challenge. So we've typically tried to use that medication more as a maintenance therapy to prevent bone loss, especially in our spine patients that we're trying to get optimized for surgery. So once they finish building their bone up, we usually transition to that. But in patients who come in on that already, that can be a challenge. So it's given once every 6 months. So when we see that, if they're not needing to build up their bone for surgery, then we'll usually keep it on. And some patients will stay on that for life. Some of the other drugs like bisphosphonates usually will do a holiday where you stop taking it after 5 years. But
the whole point is that we can build bone with some of these drugs, and we can slow down the loss of bone for the audience. And it's very complicated, and it's a very finely regulated thing in your body. But you can almost certainly think that if you've got bad osteoporosis, you would need lifelong treatment. And we're going to have to alternate these drugs. That's why you need a specialist to do it and everything. And both the bisphosphonates that I talked about, the medication that slows down the loss, and denosumab, Prolia is a trade name, they both slow the loss of bone down. But if you stop them, there may be a rebound effect in one direction or the other. Okay, so that's why you need to consider that if you have this, it's going to be lifelong treatment. And even if you take these for a long time, your bone may get so dense you may actually get a fracture. So that's why we have to have a very good program for you when these drugs are started with somebody that really knows what they're doing. And the thing we haven't covered is the building side. We actually have medications now that will build your bone significantly, and Benu, you could talk about those.
Yeah, so these are two of the newest medications. Romosozumab is actually the newest medication that's kind of come out that's been available to help with increasing bone. But two medications, the other two are a medicine called teriparatide, also known as Forteo, and then another medicine called abaloparatide, which trade name is Tymlos. And these are medicines that work on a little bit of a different pathway. They essentially simulate a hormone called parathyroid hormone, and they're kind of analogs, meaning they're a close cousin of that hormone. And when given in certain ways, it can actually increase your bone density.
And that way is?
And that way is
So they know.
injection. Yeah. And so these are medicines
Daily.
that are given by daily injection. So actually you give it to yourself, and they're provided in syringes that make it easy to do. One thing that we actually haven't talked about, which I think is important to touch on, is how patients actually get access to these medications, because there's a very vast difference.
We'll circle around to that.
And yeah, there's a really big difference, because obviously, people, we can prescribe the medications, but then they have to actually, you have to get them and you have to be able to pay for them, and so there's vast differences in the cost of these medications and insurance coverages, for these medications. And unfortunately, in the American healthcare system, this is something that I think we all struggle with our own families and whatnot. And so with a lot of these medications, the bisphosphonates especially are quite well covered by most insurance plans, because they are the first line of
Because they're low cost.
Because they're low cost, right? And they've been around for a long time. There are generics available, and so and those are really the first line of treatment for the vast majority of patients, especially for patients who aren't having spine problems where they need a spinal reconstruction type of operation, okay? Now, with some of these anabolic medicines, and anabolic means that you are building bone, so these are the things like romosozumab or abaloparatide or teriparatide. These are much more expensive medications because there are not generics available, and insurance coverage is variable for these medications. Now, romosozumab actually is unique in that it's covered by regular Medicare. And so for many of our patients, it's a blessing,
I must add to that. It is, but if your supplemental insurance, who really drives what you can get covered, doesn't like it, then it won't be covered. So a lot of times Medicare does cover it, but if you buy a supplemental, like one of the supplemental plans from AARP or whatever, they will actually sometimes not cover it, okay?
Mm-hmm.
Because they're the ones making decisions, not Medicare.
And one of the other challenges is that romosozumab was only FDA approved for the treatment of women, and so they didn't include men in the original clinical trial, and so it can be very challenging to get that drug approved in men, even though we would expect that the mechanism would work exactly the same.
But trials are ongoing for longer duration and for all sexes, but anyway, sorry, I just want to point that out because that's something that they advertise it as, but it's not 100%.
And I just wanted to bring it up because this is a practical matter in terms of getting these medications. I know Dr. Sardar, mentioned just kind of some of the socioeconomic barriers, to treating osteoporosis, and this is one of them, that unfortunately we all have to deal with, and hopefully as time goes on and that we are able to improve coverage of some of these really wonderful medications to treat people's bone health.
So let's talk about somebody comes into your practice, they need a big spine surgery, they got soft bone, a little too soft. What do you do?
So I'm gonna quickly talk about what I do then. Someone who needs surgery, the first step is going to be to identify how bad or good their bone is. So we'll do the tests that we talked about before. I won't go into that again. If I find, and even more than that, if based on some other, looking at CT scan, a few other things that are still not mainstream, if based on that we think that there is, the bone quality is not very good or there's osteoporosis, we will then advocate and really push for them to get treatment before surgery. Treatment is going to be through one of the things that we talked about. We have to make sure that they're getting vitamin D, calcium. But then typically, if you're getting surgery, we'll skip the bisphosphonates that Dr. Diamond talked about because those are the more
Slow.
slow acting, and they also are more so to slow the reversal of bone loss, but they don't really build bone as much. And we want people to build bone in this area. So we'll typically go to one of the few drugs that Dr. Amani talked about in terms of building the bone stock. And in my practice, again, if you're getting a big surgery, I typically have them be on that drug for a few months. And I won't say how many months because I think that's going to vary based on where you're going. But I have patients
Approximately range.
So for me, it's about 6 months. If you're getting a big surgery, it's about 6 months. That and depends on the drug as well. The teriparatide, abaloparatide, I typically do 6 months. For romosozumab, Evenity, it's going to be closer to about 2 months or so, because or sometimes 3 months, because it acts a bit faster, and the total duration you can use that for is also less than some of the other drugs. So we'll try to get them to build their bone stock before the surgery. I don't typically repeat testing again because you don't see a lot of changes if you do repeat testing of bone health within a year to 2 years. So typically we don't do it. We are basically assuming that we are giving you all the improvement that we can with the drugs that we have, and we want to keep some of that for after the surgery so that it also helps you heal afterwards and get the fusion. And so that's kind of the practice that we have. And just to add one more point, I know you're going to ask that question, is that we did publish recently as well on our patients who had spinal deformity, bigger constructs, patients who had osteoporosis and were treated with some of these medications, that it actually did help decrease the risk of their complications, similar to patients who did not have osteoporosis. And in fact, patients who were kind of in between osteopenia, so didn't really qualify for treatment, they did worse because we were able to improve the bone health of the patient with osteoporosis. We didn't really, right now there's not a treatment for those with osteopenia, so we're able to actually help those who were worse off and bring them closer to the normal bone compared to the osteopenia one. So which is going to be hopefully the next target for us.
Well, that's showing that ultimately we have to change the paradigm and
Right.
get these medicines used in a broader spectrum.
Yes,
But
absolutely.
Yeah, well, I'm going to let them comment about it, but what I would say is that we're at the joint spine section in Las Vegas meeting, which is a joint meeting between neurosurgeons and orthopedic surgeons who are on this panel. We all feel the same way. And all of us, Zishan and myself, the NSCN has issued guidelines for treatment about what we've been talking about, that you ought to do this before major spine surgery. You ought to consider measuring these things and doing the pre-treatment like we've been talking about. And I think that's a really important statement from two major specialties in this country, that if you have this identified, that you ought to have it treated prior to surgery. So Ben, do you differ from Zishan at all?
A little bit. So I think we're very fortunate that we have a huge bone health endocrinology group where I work, and that's probably not present at many other centers. And so they really help us to manage these drugs and help patients select the best one based on their laboratory studies as well as the imaging studies. I'm a little more aggressive than Zishan in terms of the time of treatment before surgery. A lot of that depends on the magnitude of surgery. So if they need a 15-level fusion and a major deformity versus a 1-level fusion, there may be a difference, as well as the severity of their osteoporosis. So for patients that need a significant deformity correction and have very poor bone quality, I've used up to 18 to 21 months of treatment with teriparatide or abaloparatide. It's a little bit shorter for romosozumab since that's a 1-year treatment course, and so that can be 9 to 10 months. I completely agree with Zishan in terms of continuing some treatment after surgery as well. We've actually done several studies in the lab using rabbit spine surgery models and found that when you keep treatment afterwards, it actually helps to grow the fusion mass. So when we put in screws and rods into a patient, it's really just to hold things in place while their bones grow together, kind of like a cast if you break your arm. And so if someone has poor bone quality to begin with, what would lead them to growing the bone together, and the bone that's connecting everything together would then be strong bone. So we actually do have some patients that come back 7, 10, 12 years later and have broken rods and break through where the bone was previously healed because everything that grew together was also osteoporotic. So I think it's critical to get that bone stronger too.
Perfect. Vaney, what do you do?
Yeah, I do something very similar to, kind of in between Dr. Sartor and Dr. Elder in terms of time of treatment. So I won't really, and otherwise basically exactly the same as what they do. I think pre-treating is very, very important, as well as continuing the treatment after surgery. The one other thing that I would add is that sometimes I will actually alter my surgical technique for patients
Sure.
who I think may have a more difficult time healing their bone, and so I may use different bone graft products. I may use different implants that are going to reduce the risk of some of these fractures or risk of a non-union where the bones don't heal together, just to try to give them the highest chance of success with surgery.
So you have 5 experts here that do spine surgery all the time. We kind of live, eat, and breathe it. And we've noticed that there's been a lot of complications if you don't follow proper algorithms or plans and do good preoperative planning. And one of the problems is that we've had a lot of trouble getting people to fuse, and we developed a lot of fractures above and below where we did fuse them because we didn't pay attention in the past as much as we should have to bone health, everything we've been discussing in treatment. And why is that important? Because we're trying to decrease the number of complications we have when we have to do necessary surgery on the patients out there. And that's why we've all really thought about this a lot and have come to a lot of groupthink about what we're going to do. And we have done marvelous things over the last decade. You remember how they talk about on all the news stations about how we sequence the human genome? This is a result of that because we know on a cellular level how your bones heal now much more clear than we just did a decade ago, which is how we designed a lot of these medications to work the way they do. And that's a tremendous advancement in making your surgery more successful. And so all of us have become advocates to tell you all to make sure you have good bone health and that you see your primary care doctor to check it so that we don't have emergency surgery where you have to do it on you, even though you may have bad bone, and get into a situation where we're forced to do the surgery and have a bad outcome. And that's why you can see how similar, and I agree with everybody else here, I treat my patients exactly the same way preoperatively. And I'm sure you do too. And that's why it's so important to pay attention to these things.
And Dr. Dimer, I think one of the things that you've been so great at sharing with us is that patients really need to understand what questions to ask, because getting the awareness out there to the public is important, but patients need to also understand what the appropriate treatment is for them. And so we're here to educate people.
And all the major spine societies, including the one right now, support what we're telling you and how to treat our patients. And that's an important endorsement, I think. And so when you go to your spine surgeon, neurosurgeon, we kind of think of ourselves as kind of the same breed, actually. We call ourselves neuropods and everything else under the sun. But you need to ask the question of, what about my bone health? Is it good enough to have the surgery? Particularly if it's elective. Emergency surgery or things like that, we have no choice. We have to operate. And we'll treat you afterwards, which also we haven't talked about is important. But you need to ask the question is my bone healthy enough? Because it's critical that your surgery may not be a success if it's not. So that's the question you should probably ask your primary doctor and your surgeon.
In this compartmentalized world of medicine where you have all these super specialists doing different things, everybody kind of goes, well, that's not my problem, that's not my problem, but that's not true. This bone health is everybody's problem, and it's raising awareness. Physicians are busier and busier today because of the changes in the economics of healthcare, but it's important for you to be your advocate, to ask the physician when you're getting your treatment, say, what about my bone strength? Is it good enough for this? And to make sure the testing is being done and then the treatment is being rendered.
And you can bet when you walk in there and there's a computer, you push a button, it's for service, you push it, and an AI program comes on there and says, how's your bone health? You can bet that's going to be one of the first questions they ask you if you're going to have spine surgery.
Yeah.
Each and every one of the people here have said that they have a team, that they have a primary care doctor, they have a neurosurgeon, an orthopedic surgeon, an endocrinologist, a good internal medicine doctor. And when you treat spines, you have to have a team. And so you have to have people within your practice or within your team that are no bone health and you can send your patients to get properly treated, as Ben said he has. And I think if you're going to do spine surgery, another question to ask would be, do we have a team approach to it that we can get our bone treated? Because often it's beyond my expertise as a surgeon to completely treat this problem. And so I always have several people in my practice that are specialists in this that I can send my patients to. A lot of patients that I see in my office come in and they'll tell me, and they're a little bit of round backness, they're 75 years old, they have a little bit of kidney disease, and they tell me they've had episodes of back pain over the last year. Little episodes lasted for 2 or 3 weeks, and now they had a fall and they have a compression fracture, and they're sent to you, okay? What do you tell them? Do you say that just your history would say that you have osteoporosis from what we talked about with the fracture and everything? Is that?
Yeah, I mean, I think the history tells us a lot. Before
Yes.
we even look at the X-rays, and especially older people, if you noticed over the years your back is really getting hunched, chances are you probably had a compression fracture or some kind of fracture in there. And even other things. If you've had a small fall and you fractured your wrist and you were never treated, or you had a hip fracture and you were never treated, chances are you had osteoporosis that you were not treated for. So I think history is important. We don't necessarily need to wait for other testing to kind of get an idea of what might be going on. The testing is confirmation, but history tells us, especially a lot of older people, especially women, like you talked about, with hunched back that's worsening over time, and often in communities is just attributed to age. Well, yes, it's age, but there's more to it. It's the bone that's gotten worse with age.
Exactly. And we'll see people that come in and have little episodes of back pain, and they're getting little microfractures. And we'll MRI them, and you'll see a little signal there, and they'll get better, and then come back 6 months later with another one. And so the history that you tell us is very important. What do you think, Ben? Dana?
Yeah, I mean, I think that's absolutely true. And I think it's also looking at what their risk factors are. If they're long-term smokers, if they've been
Sure.
treated with steroids for a long time, kidney disease, I think that makes you much more concerned that there's going to be a problem as well.
Yeah, and I think one of the screening questions that's actually asked for osteoporosis screening is, have you had more than 2 inches of height loss, from when you were the tallest? Basically you take your height at age 21 and where are you at now? And everyone will lose height as they get older because all of our discs age and shrink a little bit. But more than 2 inches of height loss is concerning for having had at some point in the past some type of vertebral compression fracture.
So the panel certainly agrees that history is important, and a lot of times if you just tell us what's happened, we'll have a pretty good idea what's going on.
I think it's confusing how to get access to a DEXA scan. We've talked a lot about that. As an example, I have a friend, 58 years old, was on vacation, tripped and fell, and fractured her shoulder. Had shoulder surgery, never had a bone health test, never had a DEXA scan. And, so I worry about that friend. Does that mean she probably has osteoporosis? Does it mean she should get her bone health checked? Is it hard to get a DEXA scan? Do I have to pay for it? Do I have to go somewhere special? All those questions.
I think at a minimum, she may not have osteoporosis, but I think it's absolutely important that she get evaluated for it. And I think it's very easy to get a DEXA scan. That can be done at pretty much any hospital or the majority of imaging centers. The best source would be to talk with your primary care doctor and have them give you a referral or prescription to get one completed, at least to screen for that. And any sort of minor fall with having some sort of injury, in addition to getting that injury fixed, you should definitely also always get screened for osteoporosis.
I agree. It's a simple test. It's cheap. It's very low radiation. You don't have to worry about that. And I always look at the energy involved. If you're involved in a car wreck or hit by a car, high energy injuries, and you break your hip, well, that's obviously, you may not most likely have osteoporosis. But how many of us have heard that our grandmothers fell down or fell out of bed and had a hip fracture? You can bet it's a fragility fracture, and you probably need to get a DEXA scan. So it's all, again, about the history and thinking about it and having a good way to think about these fractures and whatnot, and how they occur to really make the diagnosis. What do you think?
Yeah, I agree. And just to add to that, I know, Rita, you were asking about the age itself, and there's something to age as well. I think if you're over 45 to 50 and you have a low energy fall or injury and you have a fracture, it's going to be more likely osteoporosis, and we'll check for maybe causes behind it other than just being deficient.
Yeah.
For younger people, like if you're a 20-year-old and you fall and you fracture your wrist, there may be other secondary metabolic causes behind it as well. So there's a bit of a rule for age in terms of just saying it's an aging-based, bone loss-based osteoporosis versus another condition that's causing the bone to be weak.
Yeah.
So I think that may be where age comes in a little bit too.
It's in a way, physicians really should have a lot of common sense, and it's a common sense diagnosis that if I'm flying down a hill at 40 mile an hour and I break my wrist at age 25, I was just stupid and broke my wrist. But if I'm just walking and I trip and I land on my wrist from standing height and I break it and shatter it when I'm 55 years old, well, that raises suspicion of having a bad bone issue. And if you have any of the risk factors that we've discussed, kidney disease, renal disease in other words, or liver disease, if you drink a lot, things like that, or you're a smoker, well, then your risk and our index of suspicion goes way up. And so that's what we're trained to do. And we're the end of the pipeline. What we're trying to do is to get every healthcare provider that sees you on a day-to-day basis, on a monthly basis, or on a semi-annual physical basis to think about this. If you have a family history, or if you have any of these risk factors, or you've had a simple fracture that was splinted in the ER and treated that you shouldn't have had. And so we're trying to raise the index of suspicion in all patients out there to think about this if they have these kind of issues.
Pickleball is really highlighting this. With the explosion of pickleball, everybody's out running around doing stuff, and there's a lot of fractures occurring. And I think it's uncovering a lot of undiagnosed osteoporosis.
So we're not recommending that everybody plays pickleball. But
I thought you were going to say
well, I was thinking about it, but actually,
if you're going to play pickleball, get a DEXA scan.
yeah. But I would suffice to say that if we DEXA scanned everybody 70, there would be some degree of bone loss because that's a natural part of aging. Just like losing 10% of your muscle every decade after the age of 30 if you don't work on it. And the whole point that we're saying is there's a lot of things you can do to slow that loss of muscle strength if you exercise regularly, stop smoking, and also of loss of bone strength. And again, these are just common sense things that we think about that you should think about.
Just to add to that statistic, I mean, we looked at our deformity, like patients who were having these major reconstructions for deformity, for spinal deformity, and more than 25% had in DEXA scan-based osteoporosis, and about another 70 or so % had osteopenia, which is still not normal bone strength. So a huge majority of our patients who are going for surgery had some degree of bone loss that was less than normal.
Dr. Dimer, you talked about the explosion in biomedical engineering that has happened in the last 20 years that has resulted in the discovery of amazing new therapies and drugs that can help patients with osteoporosis like haven't been done before in the past. And one of the things you all talked about, we went into a discussion about the complicated medications and the balance that has to be struck in managing osteoporosis and bone health. And we talked about the fact that sometimes, and for some patients, they may have to be on these therapies for the rest of their lives. But I think the analogy to that is thinking about our cardiovascular health. A lot of patients with high blood pressure have to be monitored for their blood pressure medication really for the rest of their lives. And I think that a lot of times we don't think about our bones as a living, breathing, changing, dynamic organ like we think about our hearts. And I think that's something very important that the task force is doing in terms of raising awareness that our bones are an ever-changing part of our bodies, just like our heart or our lungs or our muscles or any other part of our body that's organic, that's alive and changing. And so striking that balance in treatment of osteoporosis is just like treating any other chronic condition that we have in our bodies. And are you seeing that is a change in terms of people better understanding managing their bone health? I think there has been fear amongst patients for taking bone health medications in the past.
Well, in answer to your question, when the panel can chime in, I think that bone health has generally been ignored. It's not been prioritized by any government agency as it's not cancer. So it's not one of those things that's been really at the high list of what they're going to support and articulate. But it can be equally devastating because if you have a hip fracture, your chance of dying from that is not insignificant. And so I think there's been a transitional change in how people are thinking about this, that this has now been moved into the forefront of being something that should be regularly diagnosed by primary care and the intake physicians, and should, if identified, be treated aggressively. You know, if you have high blood pressure and you're morbidly obese and you lose weight, there's a good chance you may not need blood pressure medications. But if you have bone that's lost integrity over 40 years after the age of 30, we can reverse a lot of that, but we never can make it what it was when you're 30. And remember your DEXA scan, you're being compared to a 30-year-old, right, guys? I mean, when you're 30, that's the maximum time you're going to have the best bone. And so I don't think you're ever going to be able to reverse it and not be treated, is why I made that statement. But I think we're not so frustrated that when I first started practice, you know, we could put you on calcium, vitamin D, and a pat on the back and say, well, let's see how it goes. Now, with able to actually look at the mechanism of how bone heals, which we still don't understand completely, we can actually tweak it here and there to make you not get those fractures as frequently. And that's what I think has been a transformational change in how we can treat this problem. What do you guys think?
Yeah, I totally agree. I think that you know, I think prevention, right? You know, we've talked about it a lot today, and you know, I tell patients all the time that, you know, even though you're 70 and you have osteoporosis, you know, if you're still smoking, that's one thing you can do immediately to start to change to turn the tide, basically, right? You know, if you're not exercising, get up and start to move. You know, that may only be 1 minute of walking, but that's better than nothing. And that 1 minute becomes 2 minutes, that 2 becomes 5, 5 becomes 10, and all of a sudden you're more active, you know? And so you can slow the rate of bone loss. You know, you'll still lose bone as you get older, but what you want to do is change how fast that happens. And if you already are at you know, a time point where you already have osteoporosis, you know, we've talked about all these different medications that can help to improve your bone density, reduce the risk of fractures.
So exercise is critical. Ben?
And I think that I would encourage everyone out there watching to really be empowered in your own healthcare. And so when you see your primary care physician for something else, say, well, what about my bone health? Should I be thinking about getting a DEXA scan? If I saw osteoporosis on my scan, should I be getting treatment? If you need spine surgery, talk to your spine surgeon and say, or your orthopedic surgeon if you're getting your hip replaced, and ask, should I be worried about my bone health prior to the surgery? Is that something that should be improved? And so I'd really encourage everyone to ask those questions and really be empowered in your own care.
And just to add on to what Ben said, if you're now, you know, if you've identified and hopefully you prevented, but you still have osteoporosis and you're having spine surgery, then talk about treatment. You talk about treatment before you have the surgery, so that your bones are optimized as best as they can be to then have a better outcome.
This has been a fascinating discussion, and I think it's so important for everybody to understand the information that was conveyed here to protect your health and your life. We're going to leave here with a word of advice, and my pearl is very simple. Prevention is the best medicine. And so for me, it's important for us to take vitamins. And I know that there's not a lot of permanent evidence that says vitamins work, but I think it's an insurance policy. And I think by getting vitamins into your body covers those deficits in our diet. So for me, I think everybody should have a multivitamin. I think vitamin D is an important part of a daily routine. And then it's up to you beyond that what else you want. But I think those are minimal things you should be doing. And if you're not getting enough calcium in your diet, then calcium supplementation also should be added in. So my advice is get the right nutrition to work as a preventative component of your health.
So my advice for those who are considering having spine surgery is to make sure that you discuss bone health with your surgeon, talk about the potential of whether or not you have osteoporosis, and then if you need treatment, talk about the treatment.
My advice is empowerment. I agree with what Bennett said, that I believe that you as a patient are responsible for your own health care. And this is one of the things that you need to ask about with your primary care provider is, how is my bone health? Particularly if you have any of the risk factors that we've discussed over the last hour that might make you predisposed to having that problem. And so I really like the patients to ask their doctors questions, and one of them should be, should I be concerned about my bone health, and what should you do to identify if I have a problem and treat it?
I think empowerment's critical, and I would also encourage you to talk to your family members. And so, if you have a mother who's losing height or being more hunched over, encourage her to go to her physician and get checked out and evaluated as well. And so, I think it's really, really critical to just have awareness of this entire issue and constantly be thinking about it and bring it up to all of your treatment team and family.
My advice is it's never too late to make a change. Sometimes people start to get down. They've already had a complication from osteoporosis, perhaps they've already had spine surgery and then had a fracture or it didn't heal, and you start to kind of lose hope. But it's never too late to stop smoking, get more exercise, get your weight into a normal range, do all of these healthy things that are not only going to decrease your risk of having a bone-related problem, but also just make your heart healthier, make you more active, make you more available for your family. So my advice is that it's never too late to make a change.
And I just want to say, as I said earlier, several decades ago, we didn't have any treatments. And there's no excuse really nowadays that since we do have some treatments that can actually help people with severe osteoporosis. And that's what's changed. And so it's really kind of a shame if you don't ask about treatment or it's not offered. And so we can do things now to keep you from getting these fractures and to make your spine surgery successful, which is our primary concern, of course, that we couldn't do just a decade ago. And that is reason for hope. And I think that's important for the patients.
The advances in understanding our genetics, what builds our bodies and how they function, has transformed healthcare. 8 of the top 10 selling drugs in the country are all biologics.
Yep.
And it's these biologics that we're talking about today that are transforming our health and going to help us all live better. The healthcare of last century is disappearing because we have better technology. In spinal surgery, we have better implants, we have better knowledge, but now this bone health, we have a whole new armamentarium to treat and prevent problems. So it's very exciting. We're all fortunate to live in this time of these amazing medical miracles.
We'd like everybody to take a look at our new monograph we put out, and you can go to spinehealth.org. Each and every one of the panel members here has written an article about this, and it goes a long way to explain in more detail, if you'd like, your osteoporosis. And it's easy to download in a PDF form if you'd like. So we invite you to take a look at this if you'd like. Thanks.
There have been some key words that have been spoken today: patient empowerment, hope, prevention, own your journey, and live your best life. The National Spine Health Foundation is here to give people knowledge and hope that they can take back their lives from debilitating spine conditions. You know, if you've been a patient who has suffered with a spine condition, how devastating it is to your life. And if a loved one or a coworker or family member has gone through a spine condition, you've seen that firsthand. A lot of times people will say, well, it's just about pain. It's just about bones. It's just about pain. But we're here to say we understand that if you have a devastating spinal condition, you do feel like your life is over. But as these experts have shared with us today, there is hope that you can live a better life and a better quality of life, and that there are tools that we can give you so that you can get that best care that's possible and get back to living your best life. So I want to thank the experts who are here, who are truly miracle workers. They put the best of modern science into practice every single day for their patients. They have joined me on this panel to spread that message to everybody. So I thank them for taking their practice outside of their own regions of the country and sharing it to our entire nation. And their volunteerism, their leadership, their knowledge, their expertise, their everyday devotion to this topic is so beneficial to all of us. And I thank you.